Okay, amazing. Welcome, everybody. I'm Alex Mohseni, co-founder of ClinX Academy. And with me today, I have Reza Alavi, the founder of Quintuple Aim. And our special guest today is Nima Ahmadi, the founder of the Wound Company. And Nima, so excited to have you here. So if you want to introduce yourself, go ahead.
Thank you. My name is Nima Ahmadi. I'm the co-founder and CEO of the Wound Company, which is the first value-based wound care provider and the only value-based wound care provider in the United States. I started my career in wound care building prosthetic implants for patients abroad who had suffered limb amputations, like folks in my family, and pursued a career in medical engineering and healthcare innovation based on that initial experience. Took me a while to come to wound care again. Specifically, I built a business managing over 50 million seniors on behalf of the top 70 health plans in the United States in the context of HEDIS and STARS. And then was in the wound care industry where I realized that there isn't a model of care that serves patients or payers and other providers, frankly, in an appropriate and cost-effective way, and started the Wound Company on that basis. Excited to talk about the space here today.
All right. So I guess the first thing that we want to know is, like, what is a wound? Like, I mean, I know when I cut myself or have surgery, but like, what are the different types of wounds? And let's start there.
Yeah, great question. So wounds can be traumatic, acute wounds, like if you cut yourself, if you get into a motorcycle accident, and those happen. So do burns. Those are not the wounds that I spend most of my time thinking about. When I talk about wounds and the issues in wound care and why this is right now the #1 clinical issue for the Center for Medicare and Medicaid Services in the federal government in terms of cost containment and fraud, it is about wound care for seniors. And what that looks like is pressure injuries, what are colloquially called bed sores, because there are patients who are bedridden or they may be wheelchair bound. And it's not just seniors. There are patients under 65 for various reasons who have those same situations. The majority of the patients, however, with pressure injuries are seniors in the United States. There are also wounds of the lower extremity, like what affected my family that I worked on very early on in my career. These are wounds as a consequence of diabetes, arterial disease, venous disease. And what's happening in our population is that we have many, many more seniors every year. These seniors have a higher degree of underlying metabolic disease, and they are also living longer. So you can imagine an elderly, vulnerable population living in a tissue paper shell for an extended period of time that is susceptible to injury. And it's not just a concern of the hole in the patient's body. It is also an opening by which infection can come into the patient's body, and those infections are life-threatening and limb-threatening. So sometimes we don't think about wounds enough because we think about sepsis-related hospitalizations. Well, how did the sepsis get in there, right? It's because of the wound. Or we think about diabetes, we think about cardiovascular disease, and we conflate the wound care issues that are happening and the expenses under those bigger categories. So we are, in our company, and I guess through this conversation, kind of really thinking about the hole in the patient, primarily a senior that has other conditions, as well as the whole patient, and what that, breakdown of their skin and violation of their tissue actually means for their overall systemic health.
All right, so we talk about the wound, but let's talk about healing a little bit. Like you mentioned, diabetes, vascular flow, like what in a typical patient is the best conditions for the wound to heal and the tissue and the skin to get back to normal? So what's ideal and what's kind of happening at a lot of these other places?
Yeah, it's hard, it's complicated, it depends, but I think a really good example just to sort of illustrate this is pressure offloading. So if a patient does not have the appropriate seat cushion for their wheelchair, if they don't have the appropriate specialty mattress that they are on, there is going to be continuous pressure on the wound. So they may have a huge pressure injury, 100 square centimeters on their back because of that contributing factor. Now, if a company were to come in and just do a bunch of, topical therapies, whether it's like dressings or really expensive dressings, without managing the contributing pressure appropriately, that wound is not going to get better. So the first thing that we think about as a holistic, ethical provider of wound care is, what is the contributing factor, right? Can we get an appropriate seat cushion for this patient? Can we get a specialty mattress for this patient? How do we make sure that these wounds don't happen? And then what topical therapy do we do to close that breakdown, right? But you have to think about both. On the leg, venous leg ulcers are very common. It's because in some cases there is edema or lymphedema and great swelling of the leg. If you don't manage that swelling with appropriate compression, any topical thing you do to the wound by itself is not going to heal the wound, right? So a good actor thinks about, why did this wound happen in the first place? What can we do to alleviate the underlying cause? With diabetic wounds, that gets significantly more complicated because the diabetes and blood glucose has to be appropriately managed, but there is still this concept of appropriate offloading of that pressure while creating an environment that is less vulnerable to then apply the topical therapies to heal the wound.
So let's get to the meat of the matter, like why we're even having this conversation with you, Nima. Like, wound care all of a sudden is the top topic du jour. It's all over the headlines. Everybody's talking about it. So why is everybody talking about it?
Wonderful question. So historically, there was a surgery called a tissue flap replacement, where a plastic surgeon in an operating room would take a piece of skin from one part of a patient and put it on a large wound to help create closure. Years ago, there were a new class of biotechnology therapies called skin substitutes that came out, which democratized access to what was historically a very selective, intensive procedure, basically creating artificial skin transplants that you could put on top of wounds, which would contribute to wound healing. That is a bona fide advancement in medical technology. As a bioengineer by training who worked in the space of tissue engineering previously, there is a place for those kinds of therapies, certainly, and they can be transformational in bootstrapping the wound care of certain patients. What has happened over the last decade is the way that skin substitutes are paid for has created incentives for fee-for-service wound care providers that has caused wound care expenses to go gangbusters. And that has been exacerbated by some other factors such as COVID and shifts in home-based care. And so there's been this perfect storm where there's been a new class of therapies. There's been extremely juicy reimbursement on a fee-for-service basis for these therapies. There's been an influx of private equity capital that has created this cottage industry of hundreds of these fee-for-service wound care providers who are out to find opportunities to apply skin substitutes and do surgical debridements of these wounds, which can be very lucrative, but not necessary for patients. And some of these skin substitutes have an average price of $4,700 per square centimeter that Medicare is paying for. So if you think about these patients, some of whom have 12 wounds, some of whom have a single wound that's 100 square centimeters, and how many applications of skin substitutes you can do, if the price is not appropriately regulated, and neither is the number of applications or the criteria on which you can do the applications, and you have a malicious actor, you can suddenly see patients costing $15 million in a single year because of wound care procedures done to them. And in many cases, some of those contributing factors that Dr. Alavi was asking about are not actually being appropriately managed. And so all of that money is waste and is not actually meaningfully moving the needle for these patients. And that is what CMS came out and actually says in CMS's published press release. Wound care expenses have grown by 40x in the last 5 years, and there is tens of billions of dollars in spend by the government that they did not anticipate in an environment where the government is trying to cut expenses everywhere and be hyper efficient, which is why this problem is so significant right now.
So I'm hearing a couple different things. One is, does the patient need it at all? Right, yeah. So appropriateness. Then there is, do they need this much of it? Like in that particular time, do they need like 10 centimeters, 1 centimeter, etc.? And then the other piece is how often, right? So is that fair, or are there other kind of sub pieces to this? And this is just the skin graft piece of it, right?
Right. Do they need it at all? Would it be appropriate to use? And then, how much product do you use for the wound, and how do you document product that you did not use? Because the payment for many of these folks is based on the amount of product that they use. So if they don't use all of the product, but they are claiming that they did use the product, there's an element of, fraud in that aspect as well, right? So, there's multimodal problem here effectively, right? And then there's the number of applications. We see some patients who've gotten over 35 applications in the span of 6 months of skin substitutes for a large wound, and that's what's contributing to, it being millions of dollars.
What's crazy here is the final point that you added earlier on, Nima, which is they're doing all of this high-cost treatment, but they're not doing the intervention that actually helps heal the wound, which is take the pressure off the wound.
Right, exactly.
Right.
Well, we see that a lot. Like the harder thing is the one that's going to actually drive value, right? Like how do you make sure they have the appropriate bed, the nurse comes in and turns them over, right? All the stuff that requires human capital, it's always underinvested. And then the thing that generates revenue and it has a high margin is the thing that all of a sudden private equity or others will rally behind, and actual providers are doing this work. So can you help differentiate between the fraud piece and the gray area, and then what's like actually good for the patient, right? Let's assume they are doing some pressure relief.
And they're maybe not fraud.
Yeah, like I thought the piece around, like maybe if you're putting in 2 centimeters and you're charging for 3 centimeters, like that's actual fraud, right? Like walk me through kind of the good, the bad, the really bad, and then kind of the overt fraud.
Yeah, great question. So there has been significant Department of Justice activity in this space. We saw a lawsuit for $900 million disclosed mid last year for a mobile wound provider in Arizona. In that specific case, the mobile wound provider was going after patients aggressively, including patients who are dying on hospice and applying skin substitutes. The DOJ found that in some cases, they actually weren't applying any product at all. They were submitting claims, but there wasn't product being applied. And that's just outright fraud. And there are cases, there was an incident also in the last couple of years with certain types of catheters where it was just a ghost. I mean, there wasn't actually therapy being provided. So we've seen that kind of fraud. I would say that is, in the grand scheme of the current problems, like that's an outlier. Like in most cases where there is high cost, like actual product is being purchased and applied. The other thing that we see is that these manufacturers of these products, they are providing discounts to the provider when the provider acquires these products. And the expectation of the government is that you are putting the price appropriately at which you got that product, not the original selling price. So if the price is 1,000, but you got it for 500, but you're billing the claim at 1,000 instead of the 500 that you acquired it. We have seen cases where the manufacturer has sold 2 skin substitutes to the customer and given them a huge discount. So there's a lot of nefarious discounting practices that are not being appropriately documented, and the price of the product on the receipt that's being sent is not actually reflective of the acquisition price, which means that the provider is keeping the difference. Somebody in that chain is holding on to, incremental revenue that is not appropriate, from the perspective of the federal government. There is also cases where the product that is disposed and not used is not being appropriately documented. So we're saying we used all of this product, but really, like, that wasn't the case, the size of the wound and how much you actually use versus what you're saying, right? So, that basically, like, those are different kinds of outright fraud that can happen. I don't think it would be fair to say that all of these hundreds of, clinics that have popped up, like, they're doing this kind of fraud. I think if we think about the CMS sort of like, expression, fraud, waste, and abuse, there is certainly fraud, and that has and needs to continue to be enforced criminally because, that's the only way to address that. There is also significant waste and abuse, and that is really, I think, where the opportunity is to generate cost savings and better improvements in clinical outcomes, is addressing the waste. Why are we, using an F-16 and a $10 million missile on this wound? And why are we doing that 30 times when it's not necessary, right? Like that's the over aggressive hand that is being played. And the reason that is being done is because there's a lot of money there, you know, not because it's good for the patient. And that's what I take issue with, right?
So Nima, you said something that I didn't know or realize at all. Are you saying that the way that these skin substitutes are billed is by like the actual price paid? It's not like a CPT code where the government pays a flat rate for any type of skin substitute?
Yeah, so the answer is complicated. Right now, sitting here today in 2024, it depends on where the wound, it's 2025, excuse me. It depends on where the wound care is being provided, okay? So if it is in the home setting or an assisted living facility or a skilled nursing facility, and you do a skin substitute application code, there is a skin substitute application code. You would bill that skin substitute application code with a skin substitute product code, which is a Q code. Those Q codes, that is a per square centimeter. It's being paid by the area of the wound. If you go to, you know, Johns Hopkins Outpatient Wound Care Center, the brick and mortar near where you are, Dr. Mohseni, you will, you know, not have that same incentive structure. In that outpatient wound care center, they're getting paid in a different way for skin substitutes. They have, you know, certain CPT codes based on the complexity and the type of the wound, and that's like a flat bundled fee. So if they do use the skin substitute, it's coming out of that particular bundled fee, and there's a very different, you know, incentive structure to whether or not you use them. So some CMS, you know, related data shows that, you know, it used to be the case that wound care in the home setting, if we looked at like how much skin substitute use was actually being done in the home versus in a, you know, in a non-home setting, the amount of skin substitutes in the home in 2019 was 1%. In 2024, the amount of skin substitute services in the home grew to 54%. And that is because in the home, you're getting paid by how much product you use, and you can make tens of thousands of dollars or millions of dollars. And I can share this, you know, published data with you offline. So that's the issue, right? That kind of shift is, you know, partially exacerbated by the pandemic that happened between 2019 and 2024, you know, data I referenced. But it's also driven by the perverse fee-for-service incentives that have been set up.
Okay, so I understand the fee-for-service side. To what degree is this a problem on the MA side?
So Medicare Advantage plans can basically leverage a few tools that have not been historically available for traditional Medicare. So the first is coverage policy. Medicare Advantage plans can elect to not cover a lot of the expensive skin substitutes, period, right? They can also do prior auth. They can require certain things to be met in order for that skin substitute to be utilized. And then, you know, they, within certain criteria, have to accommodate CMS payment levels, right? It's like negotiated with their providers, but their main tools are denial. Denial is what I've heard from Medicare Advantage plans. So on the MA side,
going, like, everybody hates prior auth and denials in general, right? So like, is that solving the problem and creating a new problem? Like, what's the general feedback loop of that?
Well, I would say, you know, the problem of insane wound care expenses, you know, does not exist in the same degree within Medicare Advantage because of these things. But what we see, exactly to your point, is that in MA, inpatient hospitalizations for wound are a high contributing expense because the wound is there. The hole in the patient is not getting better with denials and prior auth, right? So that's getting infected, patients ending up in the hospital. There's high post-acute spend for these patients in the SNF setting and then in the home health setting. And then you see like high home health utilization, you see high SNF utilization, high inpatient utilization for these wound patients who are extremely expensive. And sometimes, again, that gets buried under the fact that this patient's diabetic and the plan thinks, oh, this is another exhibit of our ongoing issues with diabetes. They're not actually querying their data correctly to see that there's actually a turnkey opportunity to address the wound care, which is contributing to the cost, right? There's actual published evidence showing that like a third of the costs of managing patients with diabetes is driven by their lower extremity wound care. So it is a major contributing factor to the care of these patients. And you know, sophisticated Medicare Advantage players can kind of unpack that data to understand how much of this is causal by the wound and what they can do to address it. So it does materialize in other ways. Now, if you think about hundreds of wound care companies that have popped up and have been fueled by revenues coming from this payment paradigm with skin substitutes and debridements, they are pushing those things with MA plans. So there are MA plans who've suddenly seen like 150 PMPM costs related to wound care, you know, and it's because they didn't have good policy or prior author management of the skin sub issue. And then they're playing whack-a-mole to keep up with, like, every quarter there's like a dozen new skin substitutes approved. So there's this ongoing effort that they have to commit to make sure that this, you know, problem doesn't hit them in the same way. And, you know, different MA players have different levels of sophistication about doing that.
Okay, back to what Nima, you were kind of describing the various levers that risk-bearing entities have to control wound care costs. Do you want to go over that again?
Yeah, I think, you know, first, if we look at the government, right, the government is seeing wound care as a major problem. It's been growing like gangbusters. They're trying to throw everything they can at it, right? So right now, CMS has come out in its 2026 proposed rule with payment policy changes that it wants to make. And there is like active congressional debate and extensive lobbying on both sides of this issue. So CMS is saying, hey, you know what, this whole regime where the manufacturers were coming up with their own price for these skin substitutes and providers were choosing the really expensive ones, like, we need to put an end to that. We're going to come out and put a flat fee of $125 per square centimeter on all these products. Okay, blunt, significant payment policy change. And I personally am an advocate for payment policy change. That is one lever that needs to be pulled by the government in this situation, because taxpayer dollars are being wasted at a massive scale. I mean, we throw around tens of billions of dollars. I mean, that is a tremendous amount of waste in the system. The next lever of the government is coverage policy, and that's equally important to Reza's point, right? So you have, like, how many times can I do a skin substitute application, and what needs to be true for me to do that? If you just lower the payment, but you don't do anything about coverage policy, what you'll see is that these bad actors are just going to do as many applications as they can at that lower price point to still make a lot of money, right? And we've seen this historically as well, right? The same thing happened when, you know, in other therapies, the payment rate was reduced, they went for volume, right? This is a classic fee-for-service, you know, paradigm. So coverage policy-wise, CMS under the Biden administration had a proposed coverage policy where it was going to limit the number of applications for lower extremity diabetic and venous leg ulcer skin substitutes, right? And 7 different MACs were in consensus about that. It was going to go into effect. It was delayed and then repealed under the Trump administration. There's some New York Times articles that talk about why that happened and some lobbying behind the scenes. We're not here to debate the politics of that. That coverage policy is currently scheduled to go into effect 1/1/2026. It's also highly being debated and disputed, okay? So the final lever is that the government is thinking about is this program called WISER, right? Where CMS is basically trying to play in the prior auth and utilization management space, and has put out an RFP to basically find vendors who can help it review upfront whether or not something is appropriate, right? And that's a great thing too. And I'm an advocate for the payment policy, the coverage policy, and the use of technology and efficient strategies to do upfront review. The thing that I need to keep in front of some people is that there's still a patient with a massive hole in their body that needs wound care. So you need a qualified ethical actor, a provider that you can align to the problem. Medicare Advantage organizations think of this as their network management, preferred provider arrangements, premium designated providers. So they already operate in the same world where there is network management, there is payment policy, coverage policy, and prior auth. And the government is starting to think about it that way. The government is not going to come and do a single point contract with the wound company. So we work through Medicare Advantage risk-bearing provider organizations downstream to be their preferred low-cost, high-quality wound care provider. And I think you really need all four of those things to appropriately take care of patients in a way that's cost-effective.
What do you think are the, let's say we do this, right? What do you think the unintended consequences may be, right? So like anytime there's money in a field and the field grows and they suck the money out of it, are we going to have issues with access to wound care solutions because a lot of these folks are going to move on to other things, or they're going to try to make money in other ways and wound vacs or other types of technology that's kind of under the radar now, and we'll have 400% increase or whatever it is 26 and 27, right? Like what are the
Great question. I mean, you both have been around in this industry for a while. Anything that you do is going to have some implications, some positive and negative externalities, right? So let's just take the payment policy, the $125 flat fee, right? So if CMS is only paying this much, a transactional actor is incentivized to use the cheapest possible skin substitute that they can acquire, irrespective of clinical evidence, right? And that is going to result in some revenue, maybe not the same high highs as before, but they can still play in the number of applications and still make out like a bandit. And they're using cheap product that isn't having the underlying biochemical attributes of some of the more expensive products that are backed by level 1 evidence, right? So that's one kind of, issue that I'm very sensitive to tracking, going forward. The second is you have basically, within this new payment policy, CMS is proposing to change what I described for Alex, where the outpatient brick and mortar centers were getting paid differently and creating site neutrality. So now the outpatient centers, where 52% of the skin substitute market by sales has been historically, but have not had that gangbuster incentive, now they're going to get paid per square centimeter. So if you take 100 square centimeter pressure injury, if an outpatient center was previously getting a cap fee of $3,000, they might be able to make tens of thousands of dollars on that, particular wound, even at 125 square centimeters. So I think CMS is like kind of leveling the playing field in some ways, but I fully expect to see an increase in wound care expenses for skin substitute applications in the outpatient center based on this shift, and a reduction like in the home-based center, right? Now, coverage policy, like we talked about, also plays into this, right? So the only LCD that is out there for coverage policy is about diabetic and venous leg. There is no coverage policy for pressure injuries. So you can do as many applications as you want on some of the biggest wounds out there, and that is an open gap. And that is exactly what a transactional actor is going to exploit. They're going to be finding more and more of these pressure injuries, which are very common, and doing as many skin substitutes as possible there, right? So if you go look at the stock of skin substitute manufacturers, the day the CMS payment policy comes out, you'll see that some of them, they dip by as much as 25, 33%. The next day, the stock pops back up. And in at least one of them, it's trading at all-time high territory year to date. And you have to ask yourself, like, what happened, right? Because what happened is that some people have quickly figured out how the rules of the fee-for-service game have changed and how they can benefit. And there's actual congressional legislation right now that's like the manufacturing community has figured out, hey, wait a minute, like, a flat fee could be really good, because then there's also implications for how Medicare Advantage plans have to honor the payment level set by Medicare. That opens up a new market opportunity for them, right? And so now they're pushing like, hey, flat fee sounds great. Let's basically increase this flat fee up substantially and also defer on any coverage policy because you're already doing a lot for payment policy, right? So there's active, battle happening, and people feel very strongly. Some people think that these are life-saving therapies. They're patients who are drinking the Kool-Aid and thinking that this is a shortcut without having to have their leg wrapped in compression. And there are patients who are dying whose families want to do everything for them. And that's where, these fee-for-service players are exploiting that vulnerable patient in that vulnerable phase in life. And, there's a lot of emotion, a lot of intensity, and there's real scientific and clinical evidence behind some of these products to suggest that in certain cases their use is appropriate. And we believe that too. We just don't cherry pick the most expensive ones and use them on a predetermined schedule. We would use them to bootstrap healing in cases where the patient has not responded to other interventions and all of the holistic issues are appropriately managed.
You know what this story reminds me of? Anytime you create a game, people are going to play the game, right? And you take a game like the game Go or chess, each of which has only a handful of rules, right? So like you think like, oh, there's only like 6 rules in this game. How could it possibly be a complicated game? But the game Go was considered so complicated, like the unintended consequences and the nuance of the game, that it was thought for many years that AI could never beat a human, right? But that's what's happening here, right? Like, so CMS keeps trying to like adjust the rules, but it's really amazing how there's always some sort of gaps, there's always some sort of holes, and there's people looking to take advantage of that.
Absolutely. And even before skin substitutes, there were scandals with negative pressure wound therapy. There were issues with hyperbaric oxygen. There still are with both of those therapy classes. The DOJ, before anyone heard of a skin substitute, sued the largest established wound care provider in the country for fraud, waste, and abuse related to hyperbaric. This space has always been screwed because as long as you are on fee-for-service, somebody is incentivized for your wound to be as large as possible and for you to stay wounded so that they have an annuity where they can continue to collect revenue by doing therapy to the wound. Inherently, in this clinical space, this is not a broad negative judgment of fee-for-service generally. In this space, I vehemently believe that a fee-for-service payment system will always produce issues because it does not align to the patient. If you had a capitated system where you're only getting this much, what changes? Number one, like in our business, we want to prevent the wound in the first place. That's very patient-friendly. We are incentivized to prevent the wound in the first place. Second, when there is a wound, we want to heal that as quickly and as cost-effectively as possible, which is good for the patient. And let me also make a point about that. In traditional Medicare, if you get $100,000 worth of skin substitutes and you don't have supplemental insurance, you as the patient owe $20,000. I have seen multiple patients this year who have had to owe over $20,000. And I have reviewed just in this last month a patient who was invoiced for $100,000 in coinsurance for skin substitutes. They had no idea what they were getting into. And to this point about fraud, another very common form of fraud is how they don't go to collect the coinsurance from these patients. They find these really sick, vulnerable patients. They don't go after the coinsurance and the collection compliantly and repeatedly. So they're basically letting the patient get a free pass, and they're collecting the 80% on the larger, claim submission that they're doing, right?
Let's zoom out a little. I think, and then, doing things where there's less light being shined upon it, right? So is care in the home, care in assisted living, care in nursing homes, more broadly, have opportunities for waste and abuse, even if it's not fraud, more so than places where you have a lot of med students and residents and other people around, and bright lights and people are switching shifts and asking questions of what did you do on the last shift and so on, right? Is it some of it is just a breeding ground? Is it like a petri dish for this sort of thing?
Oh, 100%. I think that's a very insightful comment that, in the home, there are fewer sort of safeguards in place. These patients, like, their situation in some cases is desperate. They're homebound. They're in an assisted living facility. They're in a SNF, which is why I think it is so important for us to have ethical actors who are taking responsibility and taking that situation very seriously for the patient, right? Because in many cases, these patients with wounds are not agentic. They can't make these decisions. They're not a good arbiter of their care, right? And so if you have an assisted living facility that's half asleep and they're letting whoever come in and do whatever to these patients, or a skilled nursing facility, Like a lot of these issues happen because of the lack of sophistication of some of the organizations, that are kind of enveloping these particular patients. That's certainly true. And like, to be fair to them, right, they would claim that we have significant staffing shortages, we have significant staff turnover, and like, we don't know wounds. Like, they're in situations that they're not, we can debate why, well supported, and that is what's being exploited by these actors. So one of the most common things that we see is like, how do these really bad wound care actors get access to these patients? They go directly to the skilled nursing facilities who will have issues of staffing, like, issues of economics of their own, and basically like say, hey, you don't know what you're doing with wounds, we'll help you check the boxes you need to check. You give us unrestricted access to the patient. And by the way, don't let anyone else into the facility. Then they go into the facility and they do what are called skin sweeps to identify revenue opportunities, right? So exactly to your point, Reza, that same thing is not going to happen down the street from you in Maryland. It's just
in these facilities, you bring a tray of Costco cookies for the staff, and you can do almost anything.
That's exactly it.
It's just how it works.
If you bring in lunch from Chili's instead of Costco cookies, you can even do more. You do whatever you want, right? And so, like that is a factor, and on the assisted living side and the home side, like home care agencies, and this is a real issue that I think the federal government needs to be doing much more about, right? So home care agencies under their episodic payment bundle from Medicare get the highest amount of payment for wound care, right? And what's happening is that because of their own lack of expertise in wound care and their lack of staffing and their own staffing related issues, and the fact that hospitals are discharging higher acuity patients to these like thin home healths with like limited staff expertise and capacity, the home healths have figured out that, hey, if we let a mobile wound clinic come in and do 2 of our 3 visits per week, we can still get paid the highest amount and outsource the work to them. And oh, by the way, we can basically have the mobile wound clinic charge Part B for supplies. So the cost of the supplies that legally need to come out of our PDGM bundle don't come out of our PDGM bundle. And what's happening is that the mobile wound clinics are going around to these home healths and entering into standard of care contracts and things with them, and sitting in interdisciplinary meetings, cherry picking patients, waiting for them to fail, the standard therapy so they can do skin subs. And there's this incredible, national, like very problematic collaboration between the home health agencies and the mobile wound clinics, which is a direct violation of the anti-kickback statute, because the home health is getting paid to do that work. They're not doing that work, and the amount of money that they're saving by not getting out there with their skilled nursing visits or billing the supplies, that itself is a measurable kickback under the anti-kickback statute when they make the referral to the mobile wound clinic. And so, there is this massive kind of like issue. And to your question, that doesn't happen at the wound care center, down the road at the, hospital, right? Like, because that dynamic doesn't exist. So, that's something we think a lot about, and we short circuit, we provide a lot of education to close those vulnerabilities by which these nefarious actors are getting in and accessing these patients.
This has been really educational. I have one kind of last question, and then I'll turn it over to Alex. Tell me a little bit more about value-based contracting. This is what I do for a living. There's so many flavors of this. Are you also taking alignment to Part A hospitalizations of these patients, or are you doing mostly the outpatient and other types of wound related? Like, so how do we know, like, if they have diabetes admissions or diabetes related wound care admissions, etc.?
Yeah. To answer the question within the question about Part A, knowing what was causal for the hospital admission is always a tricky, situation analytically, right? So often we see that like the primary diagnosis may be the infection and the wound is listed as the secondary diagnosis, right? Rarely, will you see the wound consistently being put as the primary reason why the patient was, even though the actual contributing factor was the wound. So with our customer partners, whether they're health plans or risk-bearing provider organizations, when we look at Part A, we do an analysis looking at what's the inpatient burden for where the wound is the primary diagnosis. Then we look at secondary and then tertiary. And I think when you get to a space somewhere between secondary and tertiary, you have a good approximation of how much money we're losing for hospitalizations related to wounds specifically. And that is what we think about as part of the overall baseline that we contract around. A significant portion of our baseline is the actual Part B spend, driven heavily by these skin substitutes, debridements, and unnecessary other therapies, of which we haven't talked about all of them in this call, but there are other unnecessary, questionable therapies being done at a very high degree. So there is already massive waste in that category, right? So we have some customers where our value-based contracts are just based on the Part B component. We have others where it's based on the Part A and the Part B component, right? And you know, it requires varying levels of sophistication, and it varies based on the type of the organization that we're working with, right? Some of our organizational partners are vertically integrated medical practices where, in addition to the claims data, they have their own systems for recording what was the hospitalization event driven by, right? And so we have additional metadata that we don't in other cases, right? Working with like an MA plan, for example. And to answer your question, Reza, sorry, Alex, just you asked what's value-based contracting. It's like either, you know, full subcapitation of the wound care cost or some sort of like, you know, a PMPM arrangement where we're basically getting like this flat fee. That's the important thing, where you're taking away the volume of procedures as the incentive and providing some share of economics so we can get out there, get a very expensive certified provider or nurse seeing this patient, right? And I mean that point seriously, like wound certified nurses and providers are very limited and they're like practicing at the top of their license. You know, it's like the peak in some cases of what a, you know, nurse can do is the wound and ostomy care, right? So in order to get these highly qualified actors to be seeing these patients, particularly driving around into the home ALF SNF setting, if you're doing it on a fee-for-service basis and only doing what's medically necessary, it is a massive money loser. It's not even like sustainable at all, right? So we have to be under some value-based arrangement to get just enough economics to make this Toyota Camry of wound care model, you know, go, right? And that's basically what we're interested in, creating financially sustainable structures under which we can provide the highest quality, cost-effective care to patients nationwide.
I'd love to hear from you, Nima, maybe whatever you're willing or able to share about your biggest wins and successes both at the individual patient level and maybe also at the client level. Like, talk to us about some of the big wins.
Yeah, I mean, you know, we have successfully reinvented at national scale the payment model for wound care and demonstrated that under a value-based paradigm, patients are able to get higher quality, cost-effective care. And that has been a major, you know, lift, because when we started, we knew, you know, I was at whether, you know, in the streets of Detroit and rural Mississippi, I knew and I saw what the perverse incentive structure was doing and what kind of behavior was being generated long before the New York Times ever heard of a skin substitute or wrote an article about it, or CMS realized what the problem was. Back in 2022, it was really hard to convince people that wound care was a growing issue and a problem, right? And some people were asking the questions, even though they worked in medical roles at plans and provider organization, what's a wound? What is this thing? Why do I even need to worry about this, right? Some of them like, you know, it was shocking to me, right? And so I look at our greatest victory as having brought early awareness to this issue and built a solution that once the problem really started to go hockey sticking, that there was an alternative available for health plans and providers, and that we anticipated that. I think that's been our greatest win broadly. On a patient level, I celebrate everything that our, you know, distinguished nurses and providers do. It is really hard work. It is not the kind of thing you talk about at a cocktail party. We're dealing with like odorous wounds, rotting flesh. There are maggots in some of these wounds. Like, this is not pretty, you know, but this is for the patients who have these wounds and their families. this is really life altering. And there are people out there who are certified, who have dedicated their career. And I'm proud to be one of the organizations that has aggregated the very best of them and aligned them to this problem in a payment model where they get to do what's right for the patient. And I know you both as providers can appreciate this. There are providers being pushed to do certain therapies that they don't agree with, right? And that's also problematic because there are good providers out there. They deserve to be under an incentive structure where they can practice good medical care and exercise appropriate clinical judgment without having a target for how much skin substitute they have to do, what skin substitute product with juicy reimbursement they have to use, and how many debridements they have to do. And unfortunately, that is still the vast majority of wound care companies in this country.
Amazing. Nima, thank you so much for educating us and sharing so much of this content. This was super helpful, really amazing. And I think folks can find you at the website, it's thewound.co, correct?
The Wound Company, yeah. Or on LinkedIn. Thank you very much, both of you.
Thank you, Nima. Thank you, Reza.